Another little finer point, for repeat TURBTs, let's say you're going in, someone has a history of high-grade T1, you're re-resecting, you see a scar. Are you formally re-resecting those every time, or do you do biopsies, or does it depend?
It depends to some degree. I do formally re-resect them, in particular if their bladder has seen a lot of intravesical therapy. Because when you think about some of the data coming out with really long duration of bladder preservation, because we have a lot of agents, and you look at the bladder and the scar and the remodeling, I get more worried about things under the mucosa, which is what I see actually quite a bit. It's fine. The surface urothelium is fine, but underneath it's not fine. So in those situations, I do tend to actually re-resect the scar or previous areas. When you're going to re-resect for a high-grade T1 and you need muscle sampling, you need muscle sampling. So if you're going to get that with your biopsy, fantastic. But if you need a loop, then that's probably necessary. You can look at other things like what's the state of someone's urethra and bladder neck. Particularly, many patients have had prostate cancer and radiation and those types of things. And you can say, okay, do I need to put a resectoscope in? So do I need to do urethral dilation, put a resectoscope in to get muscle? If you look in that bladder and you do, then you got to do it. But if you look in there, you're like, okay, this was a small tumor on a little stalk, but it was T1. I can get muscle in the one biopsy bite. So then you choose to do that and kind of go with the smaller scope, right? So I think you can use all those factors in deciding, again, how much do you need to do and how much do you not need to do to help with patient tolerability. But in the end, you kind of got to know why are you doing that procedure to begin with and what information do you need to make the next right decision, right? So that's kind of how I look at re-resections or multiple resections.
I kind of go through a checklist with the trainees in the operating room. I ask the same questions for each case. Could we cure this patient today? So is it papillary disease that with a good resection that you could potentially cure the patient? Do we need to sample muscle? Yes or no. If it's recurrent low grade and it's a small low grade appearing tumor, you don't necessarily need to sample muscle. And then just kind of another cautionary tale I see, sometimes with the trainees is when you're going back in, especially for restaging for a high grade T1, you want to sample muscle in the resection bed, not in the penumbra or the surrounding tissue. That doesn't help us, right? So you have to take the deep bite or the deep swipe with a resectoscope in the resection bed at the index resection.
Yeah, that muscle sampling question is tricky. I've always wondered, does it really matter if you get one little whiff of muscle from one place, or do you really need all of the muscle underneath the entire resection? I don't think we have a good answer to that question. I saw a really interesting study from Japan recently where they actually did repeat TURBTs, and if they were negative, they would just do watchful waiting, and the outcomes were pretty good. So doing a good resection, can't be understated.
That was seen in a few randomized controlled trials, right? Nimbus study, totally different, slightly off topic of what we're talking about, but looking at using less intravesical therapy, BCG. And the interesting thing in their study is that they did a re-resection until there was no residual disease. So sometimes patients had 3 TURs prior to intravesical therapy, and the recurrence rates across both groups, and even the usual standard BCG group, was some of the lowest that we've ever seen. So I do think there's some nuance to how big of a TUR do you need to do. Obviously, if you go too intense and it takes someone 3 months to recover, that's not really ideal if you're planning intravesical therapy. So there's probably a balance there.